You know, usually when we talk about a medical diagnosis, there's this expectation of like absolute precision, almost like engineering.
Oh, definitely.
And
Like it's binary,
yep.
broken or not broken.
Exactly. You break your arm, you get an x-ray, it shows a jagged white line, and the doctor just points at the film and says, there it is.
Right. It's clean. And frankly, it's comforting. I mean, we humans, we like things to be visible and easily categorized.
But then you step into the world of dermatology, and suddenly that metaphorical x-ray machine is just, it's totally useless.
It really is.
We are looking at a diagnostic landscape that is incredibly murky. You're presented with a patient who's covered in a rash, and the skin is essentially acting as a canvas, right? Displaying like 100 different potential systemic issues.
Yeah, it's the absolute definition of diagnostic muddy waters.
Right.
I mean, the skin rarely just gives you a straight answer right away.
Which is exactly why we're doing this deep dive today. We're looking at the ultimate human check engine light, the skin.
The largest organ of the body.
Right. So we've got our hands on a foundational medical text, Requisites in Dermatology General. It's edited by Catherine Schwarzenberger, Andrew E. Werchniak, and Christine J. Coe. And whether you are a medical student cramming for your boards, a young professional stepping into the clinic, or just, an insanely curious learner who wants to understand the human body, this is for you.
Our mission today is to provide a really comprehensive, scientifically precise, but still accessible synthesis of this text.
And we're not just reading a list of symptoms.
No, not at all. We want to decode everything from reactive rashes and blistering disorders to genetic conditions. We want to break down exactly how these diseases work on a cellular level and equip you with practical clinical pearls.
Okay, let's unpack this. We're going to treat this like an audio masterclass. I'll be asking all the naive questions, and we will rely on you to provide that authoritative breakdown on exactly why these clinical distinctions matter. So where do we even begin with something as vast as the skin?
Well, let's start with something almost everyone has experienced at some point.
Oh.
The itch.
Oh, yeah.
Specifically urticaria, which most people just call hives. Clinically, urticaria is characterized by the classic wheel and flare reaction.
Yeah.
You get transient cutaneous edema, which is just fluid swelling in the skin, surrounded by this blanchable redness.
Blanchable, meaning if you press it, it turns white.
Exactly. Now, the critical distinction the textbook makes here is the timeline.
Right, I noticed that. It divides it into acute, which is under 6 weeks, and chronic, extending beyond 6 weeks. But then it gets really specific about a 24-hour rule for an individual hive.
Yes, the 24-hour rule is huge.
I like to think of this as a diagnostic egg timer. But why 24 hours? What magically changes when that timer goes off?
It comes down to the underlying mechanism. A standard allergic hive is essentially just a temporary fluid leak. Mast cells in the skin degranulate, releasing histamine, right?
Right.
And that histamine causes your blood vessels to briefly open up and leak fluid. But that fluid gets resorbed quickly. So within 24 hours, that specific hive should either vanish completely or, move to a different spot.
Okay, so what if the timer goes off and that specific individual hive is still sitting exactly there on the skin?
If it persists beyond 24 hours, or if the patient tells you it burns rather than itches, or if it leaves purpura behind.
Wait, what does leaving purpura mean in this context?
Purpura is basically a bruise. It means red blood cells have actually leaked out of the vessels and become trapped in the skin.
Oh, wow.
Yeah, so if you see that, you are no longer dealing with a simple histamine fluid leak. You're likely dealing with physical, structural damage to the walls of the blood vessels themselves.
So the whole diagnosis completely changes. It's no longer just an allergy. What does a clinician do with that information?
It means you must perform a skin biopsy. Lesions that break that 24-hour rule require a biopsy to rule out a much more serious condition called urticarial vasculitis.
That is a massive clinical pearl right there. Now let's look at a different scenario. What about the patient who comes into the clinic itching out of their mind, but they don't have a rash at all? The text refers to this as diffuse pruritus. I just don't understand how someone can be scratching constantly, but there are no primary skin lesions like hives or blisters.
It is a confusing presentation, for sure, but it raises a critical red flag. If the skin itself looks normal structurally, but the patient is itching everywhere, the skin isn't actually the primary problem.
It's acting as an alarm bell.
Exactly.
Right.
It's an alarm bell for a systemic internal issue. You have to start investigating internal organs. You check for renal insufficiency, hepatic cholestasis, which is a liver bile issue, endocrine abnormalities, or even HIV and internal malignancies.
And the text mentions a brilliant visual clue for this called the butterfly sign.
Yes, the butterfly sign is fascinating. It's a patch of completely normal, unscratched skin right in the middle of the back, shaped a bit like a butterfly.
Because they literally can't reach it.
Exactly. It exists for one simple mechanical reason. The patient physically cannot reach that area to scratch it.
So if you see secondary lesions like excoriations or those thick scratch-induced nodules everywhere on the body except that mid-back area, that tells you the itch came first, from the inside.
Right, and the scratching is what caused all the visible skin damage.
That makes so much sense. And to treat that kind of systemic internal itch, the text highlights a specific treatment, right? Narrowband UVB or NBUVB therapy.
Yeah, NBUVB.
Light therapy. I mean, how does shining a light on the skin fix an itch caused by kidney or liver disease?
It's really cool, actually. Narrowband UVB delivers a very specific wavelength of light, exactly 311 to 313 nanometers. It penetrates just deep enough into the epidermis to alter the local immune function.
Without burning them.
Right, it quiets down the overactive nerve endings in the skin without the severe side effects you'd get from broad-spectrum UV light or, heavy systemic immunosuppressant drugs. It essentially turns down the volume on the skin's itch receptors locally.
Okay, staying in the realm of itchy rashes, the text spends a lot of time on something called spongiotic disorders, which basically means the eczemas. Spongiosis sounds like a sponge. What does that actually look like under a microscope?
That's exactly what it looks like. Spongiosis means there is excess fluid building up specifically between the skin cells in the epidermis, spreading them apart so the tissue literally resembles a sponge.
And under this umbrella, there are three major presentations, right? First is atopic dermatitis, which is the classic eczema. The text mentions a mutation in something called the filigrein gene for this. How does that cause the rash?
Think of the upper layer of your skin, like a brick wall. Filigrein is a protein that acts like the mortar, helping to bundle keratin filaments together to keep that wall tight and waterproof.
Okay.
If you have a mutation in that gene, the mortar is defective. The skin's barrier becomes leaky. Moisture escapes, making the skin incredibly dry, and environmental allergens easily slip in, which triggers chronic inflammation.
Got it. Leaky skin barrier. What are the other two presentations?
We also have dyshidrotic eczema, which presents as these intensely itchy, tiny, tapioca-like fluid-filled vesicles, almost exclusively on the palms of the hands and the soles of the feet.
Ugh, those sound awful.
They are very uncomfortable. And finally, there's nimmular eczema, which presents as these coin-shaped, heavily exudative, scaly plaques, often on the arms or legs.
Let me ask a practical question from the text, though. A patient comes in with severe hand dermatitis. Say they work in a kitchen, or maybe they're a nurse. How do you practically tell the difference between irritant contact dermatitis, or ICD, and allergic contact dermatitis, ACD? To the naked eye, they look practically identical.
They do, and honestly, they often coexist in the same patient. But the underlying mechanisms are completely different. Irritant contact dermatitis is purely non-immunologic.
So it's not an allergy.
Right. It is straightforward physical or chemical damage to the skin barrier. Imagine a bartender washing their hands 50 times a shift. The soap simply strips the lipids away.
An allergic contact dermatitis.
That is a type 4 delayed hypersensitivity immune reaction. The immune system is actively attacking a specific substance, like nickel or a fragrance.
So how do you confirm which one it is?
To truly tell them apart, you rely on a detailed exposure history and, crucially, patch testing. You apply suspected chemical allergens to the patient's back, wait 48 hours, and see if the immune system mounts a specific, localized eczematous attack on that exact spot.
Okay, so we've talked about what happens when fluid builds up between cells, creating the spongy eczema. But what happens when the skin's production cycle goes into massive overdrive?
Then you move into the papulosquamous diseases. The classic example here is psoriasis. Histologically, there is rapid out-of-control turnover of the epidermis.
The skin cells are multiplying too fast.
Far faster than they can shed. Clinically, this presents as sharply demarcated bright red plaques covered with a thick, silvery scale, often on the elbows, knees, and scalp.
But the text directly contrasts psoriasis with a much rarer condition called pityriasis rubra pilaris, or PRP. I want to break this down because there is a lot of jargon here. You aren't just looking for red plaques, you're looking for orange red plaques.
Yes, the color is distinct.
And the text mentions follicular hyperkeratosis and palmoplantar keratoderma. Can we translate that?
Absolutely. Hyperkeratosis essentially means the skin is overproducing keratin. In PRP, this happens right at the hair follicles, creating tiny, rough, sandpaper-like bumps.
And the palmoplantar part.
Palmoplantar keratoderma simply means a massive thickening of the skin, specifically on the palms and soles, almost creating an orange, waxy cast.
But the most striking visual clue for PRP has to be what they call the islands of sparing.
Yes, it's very distinct. In a patient covered in this widespread orange-red rash, you will find distinct areas of completely normal, perfectly healthy, unaffected skin entirely surrounded by the rash.
It literally looks like an island of normal skin in a sea of inflammation. From there, the text pushes deeper into the skin, past the epidermis, down into the subcutaneous fat layer. Inflammation of this fat is called panniculitis. Now, here's a diagnostic method I need to question.
Okay, shoot.
The text says to diagnose panniculitis, a standard quick punch biopsy won't work. You need a deep excisional wedge biopsy. Why can't I just take a regular punch biopsy? It's so much easier on the patient.
I like to use a real estate analogy for this. A superficial punch biopsy is like taking a core sample of a single house. It tells you what the house is made of, but it tells you absolutely nothing about the layout of the broader neighborhood.
Right.
To diagnose panniculitis, the pathologist needs to map the entire city block.
What does the city block look like in fat tissue?
The subcutaneous fat is structured into lobules, which are like the houses, and those lobules are divided by fibrous septa, which are like the streets.
Oh, I see.
A narrow punch biopsy just can't capture that geometry. With a large wedge biopsy, the pathologist can classify the inflammation into one of four fundamental patterns. Is the inflammation primarily in the streets, the septa, or is it in the houses, the lobules? And for each of those, is there associated vasculitis or no vasculitis?
So while some conditions build up thick scales or inflame the deep fat, others make the skin literally fall apart. Let's look at the blistering or vesiculabilis disorders.
For blistering disorders, the entire diagnostic key rests on identifying the exact anatomical level where the skin's layers are splitting apart.
If the split is very high up, right under the top layer of dead skin, an intracorneal or subcorneal split, the text says you get very fragile blisters that pop incredibly easily.
Right. A prime example is pemphigus foliaceus. This is an autoimmune disorder where the patient's antibodies mistakenly attack a protein called desmoglein 1.
Desmoglein 1.
Yeah, it acts like the glue holding the very uppermost epidermal cells together. When that glue is destroyed, the top layer simply slows off, leaving shallow erosions.
Now compare that to dermatitis herpetiformis, or DH, which also has a high subcorneal split but presents completely differently. DH presents as intensely itchy, small blisters distributed symmetrically on the elbows, the knees, the buttocks. But the underlying systemic mechanism here is wild.
It is a profound connection. Up to 95% of cases of dermatitis herpetiformis are directly linked to gluten-sensitive enteropathy, better known as celiac disease.
Wait, really? How does eating gluten cause symmetrical blisters on your elbows?
It's crazy, but when a patient with celiac consumes gluten, their immune system forms IgA antibodies against an enzyme in their gut called tissue transglutaminase.
Okay.
Unfortunately, those gut antibodies enter the bloodstream and cross-react with a very similar enzyme in the skin called epidermal transglutaminase.
So the immune system essentially gets confused.
Exactly. It attacks the skin enzyme, and that causes the intense inflammation and blistering.
To officially diagnose DH, the text stresses the necessity of direct immunofluorescence, or DIF testing. Logically, if I see a blister, my first instinct is to take a tissue sample right from the center of it to see what's inside. Is that what you do?
Actually, no. That is a very common diagnostic trap. You must biopsy the normal appearing perilesional skin sitting right next to the blister.
Why normal skin? That seems counterintuitive.
Because if you biopsy the blister itself, the tissue architecture is already completely destroyed, and the delicate immune complexes you're looking for have been chewed up by the inflammatory response.
Oh, that makes sense.
Yeah, the normal appearing perilesional skin still holds the intact immune deposits. In DH, if you biopsy the healthy-looking skin next door, you'll find granular IgA deposits sitting right in the dermal papillae.
That is fascinating. Okay, let's pivot to cutaneous infections. We have a whole zoo of microbes to cover. For viral infections, the text highlights the varicella zoster virus, which causes chickenpox and shingles. And it mentions using a zinc prep at the bedside to diagnose it. But I have to challenge this. In the modern age of PCR testing, isn't scraping the base of a blister, smearing it on a slide, and looking for multinucleated giant cells a bit outdated?
It is a fair challenge. A PCR test is undoubtedly the gold standard for sensitivity and specificity today. However, I will strongly defend the zinc prep.
Why is that?
Because it is an immediate bedside sneak peek. PCR takes time to run in a lab. If you have an immunocompromised patient with a rapidly spreading, painful vesicular rash, a quick Zank prep, revealing those giant cells, gives you the confidence to start 5E antivirals right there in the room while you wait a day or two for the confirmatory PCR.
Okay, so it's a bridge to the definitive answer. I can accept that. The text also mentions a viral infection called ORF. I'm less familiar with this.
ORF is caused by a parapox virus. It presents as a solitary, weeping, sometimes bloody nodule almost exclusively on the hands. The key here is the clinical history. You will almost always find a history of the patient handling infected sheep or goats.
Sheep or goats, wow.
Yeah, and the clinical pearl for ORF is patience. It looks alarming, but it's a self-limited condition that resolves entirely on its own in 3 to 6 weeks.
Moving to fungal infections, we have pityriasis versicolor. The text says this is diagnosed by tape stripping the scaly lesions and applying a chemical stain. And under the microscope, it has this classic spaghetti and meatballs appearance. Why does it look like that?
It's an unforgettable visual. It's caused by the Malassezia fungus. The spaghetti are the short fungal hyphae, the branching filaments.
And the meatballs.
The meatballs are the round yeast spores of the fungus. Seeing both forms together confirms the diagnosis.
But we must urgently shift gears to bacterial infections, specifically necrotizing fasciitis. The tone of the textbook shifts dramatically here.
It has to. Necrotizing fasciitis is a true surgical emergency. It initially presents as rapidly spreading redness, swelling, and a level of severe pain that is wildly out of proportion to how the skin actually looks on the surface.
You don't wait for lab cultures for this,
No.
right?
Absolutely not. You require immediate hospital admission. You must do a deep biopsy down to the superficial fascia to confirm the extensive vascular thrombosis, the blood clots cutting off circulation, and the tissue necrosis.
That sounds terrifying.
It is. You immediately initiate broad-spectrum IV antibiotics, and more importantly, you secure early surgical consultation for aggressive debridement. The tissue destruction moves at a terrifying speed.
Okay, taking a breath from that. Let's zoom in on a very specific and universally frustrating anatomical structure, the pilosebaceous unit. Let's talk about acne versus rosacea.
Acne vulgaris is driven by 4 interwoven factors: follicular plugging, massive sebum production, the bacteria Propionibacterium acnes, and resulting inflammation. But diagnostically, the absolute hallmark is the comedone, what we commonly call blackheads and whiteheads.
I always think of the comedone as a cork in a bottle. Is that an accurate way to visualize it?
It is a perfect way to visualize it. Once that cork of keratin and dead cells plugs the top of the follicle, the sebum oil is trapped underneath. This creates a dark, oxygen-deprived environment, which is exactly where the P. acnes bacteria thrive.
Oh, gross.
Yeah, they multiply rapidly behind the cork, triggering an inflammatory explosion.
So if a patient comes in with a red, bumpy face, but there are absolutely 0 comedones, no corks, you have to pivot your diagnosis.
Completely. If comedones are absent, the diagnosis often shifts to rosacea. Rosacea lacks that follicular plugging. Instead, it is characterized by vascular lability,
Which noted.
prolonged flushing that eventually leads to permanent vessel dilation known as telangiectasia. There's also a clinically relevant link to an overgrowth of Demodex mites living inside the follicles, triggering an immune response.
The text also offers a crucial pearl regarding severe acne in adult females. Say you have a female patient with treatment-resistant acne, particularly deep cysts along the jawline. Why does the text say you can't just keep throwing topical creams at it?
Because the topicals aren't addressing the root cause. You have to screen that patient for polycystic ovarian syndrome, or PCOS.
Ah, hormones.
Exactly. In PCOS, excess androgens, male hormones, systemically drive the oil glands into overdrive. You have to treat the hormones internally to ever clear the skin externally.
Let's stay with the follicle and discuss hair disorders, or alopecia. The text says the initial clinical step when evaluating hair loss is determining if the alopecia is scarring or non-scarring, meaning are the little pores the hair grows out of still open and viable, or have they been permanently replaced by smooth scar tissue?
Correct. If it's non-scarring, you can perform a gentle hair pull test and examine the extracted hairs under the microscope. The morphological clues are fascinating.
Like what?
Well, if you look at the hair bulb and it is pigmented with a ruffled cuticle that looks like a rumpled sock, that points to loose anagen syndrome where the hair just isn't anchored properly.
And what if the hair ends in a non-pigmented, firm, club-like shape?
That is a telogen hair. It points to telogen effluvium, which is a massive shedding phase, usually triggered by a major systemic shock like severe stress, high fever, or severe illness. The body prematurely forces the hair follicles into the resting phase to conserve energy.
We also can't forget infectious causes of alopecia. The text notes that tinea capitis, a fungal infection of the scalp, is incredibly common in children but is frequently missed in adults. Why is it missed?
Because in adults, it presents much more subtly. It rarely causes giant bald patches. Instead, it presents as fine dandruff-like scaling or as tiny black dots right at the scalp surface.
What are the black dots?
They're actually the infected hair shafts that have become so brittle they snap off flush with the skin. A simple microscopic scraping can prevent years of misdirected steroid treatments.
We've looked at what happens when follicles become inflamed, but what happens when the skin cells themselves multiply out of control, or when genetic coding goes awry? That brings us to growths and genetics. Let's start with benign epidermal tumors, specifically seborrheic keratosis, or SKs.
SKs are incredibly common as we age. They classically appear as these stuck-on, waxy, pigmented papules. And the pathognomonic histological feature of an SK is the presence of surface horn pseudocysts.
Break that down for me. What is a horn pseudocyst?
Essentially, as the SK rapidly overproduces epidermal cells, it invaginates, creating tiny pits. Those pits fill up with compacted keratin, which is the horn material. Under a dermatoscope, they look like tiny little white or yellow pearls embedded in the lesion.
Here's my question, though. If SKs are perfectly benign, non-cancerous growths, why do we dedicate so much textbook space to them? I mean, why do we care?
We care deeply because of their ability to mimic danger. A deeply pigmented or irregularly shaped SK can perfectly mimic the visual appearance of a malignant melanoma.
Oh, I see.
Yeah, if the visual diagnosis is ever in doubt, if you aren't absolutely positive you see those classic horn pseudocysts, a biopsy is legally and medically essential to rule out a deadly skin cancer.
Moving from growths to genetics, the text dives into a condition called Derrier's disease. It says it's an autosomal dominant disorder caused by a mutation in the ATP2A2 gene. But what does that actually mean for the patient's skin?
It comes down to cellular machinery. That specific gene codes for a calcium pump inside the cells. Think of skin cells like bricks, and structures called desmosomes are the mortar holding them together.
Okay, more mortar.
Right, and that mortar absolutely requires a precise balance of calcium to set and hold firm.
So without that specific pump?
The calcium balance is disrupted, the mortar fails, and the epidermal cells literally lose their grip on each other. Clinically, this presents as greasy, hyperkeratotic papules, often on the chest or back. And uniquely, it causes V-shaped nicking at the free edge of the fingernails because the nail matrix cells are also losing their adherence.
Amazing. Finally, let's touch on pigmentation disorders, specifically vitiligo, where autoimmune destruction of the pigment-producing melanocytes leads to stark white patches. The text brings up the use of a Woods lamp for diagnosis. How does a special light help you see white spots?
It relies on basic physics. A Woods lamp emits a very specific band of UVA light. Melanin, the pigment in normal skin, strongly absorbs this UVA light.
Okay.
So normal, healthy skin with pigment will appear much darker under the Woods lamp. This dramatically enhances the visual contrast of the depigmented vitiligo patches, which reflect the light. It allows you to see the true, often hidden extent of the disease, especially in fair-skinned individuals.
We have covered a massive amount of ground today, but if you synthesize it all, whether you're dealing with the vascular damage behind a 24-hour hive, spotting the islands of sparing in PRP, recognizing the gut-skin gluten connection in DH, or finding the cork in the bottle condom of acne, dermatology is ultimately about recognizing underlying mechanisms.
It really is.
Let's put this into practice for everyone listening. Imagine I walk into your clinic right now. I have intensely itchy, irregular, raised red plaques all over my arms. I tell you, these spots have been appearing and disappearing for months. You take a pen and draw a circle around one specific lesion.
Okay, I'm with you.
I come back 48 hours later, and that exact lesion is still inside the circle. But now, I tell you, it burns, and it looks like it's leaving a bruise. Based on the textbook, what is the likely diagnosis, and what are you doing next?
Well, because that individual lesion violated the 24-hour rule, shifted from itching to burning, and left purpura, a bruise, I am no longer thinking about a simple allergic fluid leak.
Right.
The diagnosis is suspected urticarial vasculitis, meaning the blood vessels themselves were damaged. And my absolute next step, before anything else, is a skin biopsy.
Nailed it.
And I want to leave you with a final provocative thought. We spent this entire deep dive looking at the skin as an organ, displaying its own symptoms, rashes, scales, blisters. But consider this. What if the skin is actually the ultimate real-time check engine light for the entire human body?
Hmm.
How much invisible internal pathology from unrecognized celiac disease destroying the gut, to silent renal failure, to systemic hormone imbalances is broadcasting itself right there on the surface, just waiting for a clinician trained to read the signs?
So the next time you look at a rash, remember sometimes the diagnostic x-ray machine isn't broken. You're just looking at a completely different kind of film. Thanks for joining us on this deep dive.